Hi, so I'm going to talk about CLI treatment, the endovascular options. This is a pretty expansive topic. Each category itself is close to a 45-minute to an hour's lecture, so I'm going to try to condense it and give you the key points. No relevant disclosures. So when you approach, always keep the patient in the middle. Let all the procedures and the strategies meet the patient. Personally, I'd like to achieve direct revascularization, which is the angiosome-based technique. Use the least invasive strategy to get the job done. Again, don't hesitate to stage the procedure. Always think of surgical options and never forget that you can always do hybrid strategies for certain complicated disease. So there are two sides of the coin when we talk about endovascular. One is how do you cross the lesion and the CTO, and the next thing is what treatment strategies you have available. So again, assess the anatomy, usually up and over. Certain cases you have to use antegrade, and always keep the retrograde option open because sometimes the CTOs are easier to cross and it increases your success. Define the cap as well as the main body. Now, usual technique to cross is to use the wire and support catheter. So get familiar with the few. Make sure you bring the right kind of wire for the right kind of CTO so you understand what the lesion is, and therefore whether you need a high penetrating power or low penetrating power, you need a hydrophilic or so on and so forth. There's a whole slew of wires, but you can pretty much put them into these four categories. And once again, I say get familiar with a few so your hand learns that muscle memory, and also you know how the wire behaves in different lesions. Here's a whole bunch of support catheters. There's every 6 months or so, they keep coming up with new ones. Once again, I think it's good to get familiar with a few. This is the technique where you go subintimal and then you cross back into the true lumen. This is a case where we couldn't enter from up top because of the calcium that you see there, but we were able to find a channel retrograde. Here's a case where we got access from below and then created a few channels, and then we were able to enter the true lumen, actually antegrade. So the other technique is the card technique, essentially adopted from the coronary CTOs. Essentially, you have balloons from either side and you create a dissection plane and you try to enter into the other side, either from above or below, and therefore it's called cart or reverse cart. Cart being if the balloon is inflated in the retrograde, and reverse cart when the balloon is inflated in the antegrade side. And then here's an example. Here's another example of reverse cart where you have the balloon inflated up top and then you come from wire from below and then you snare it. Here's another case where you have a balloon inflated from below and then you poke through with an out back and then you snare the wire out. Here is a advanced technique where you use transcollateral to revascularize the the CTO. Here's an example of where you have double retrograde axis and you pretty much recreate the popliteal artery as a bifurcation. Here's a technique where you can use IVUS guidance to perform your re-entry. You kind of orient yourself with the IVUS and with the fluoroscopy, and then you change the angles in the fluoroscopy and you see how your IVUS behaves, and then you use your second wire to poke into the true lumen. Here's another example where you use transcutaneous ultrasound to actually visually see where your wire is. So this kind of gives you more a 3D, view. The other thing is then disrupting the calcium, not able to cross through it. You kind of loosen the calcium and you do it transcutaneously. Keep in mind, know the anatomy underneath so you don't injure any nerve. Again, you have a whole bunch of crossing catheters, specialty ones for below the knee. But personally, I've found that these are very challenging to use and they've not had as much success as you have it in the SFA. Here are some advanced catheters with extendable tips and which can fracture caps and then which can, change their shapes distally. So now that you've crossed the lesion and the chronic total occlusion, the next thing is how do you manage this? So there's a whole slew of treatments, and unfortunately, nothing is really panned out to be definitive. and kind of become mainstream. So we'll go through a few of them. So plain balloon angioplasty, as we've seen from the basal trial, surgery stands out better with regards to patency. And when you look at this meta-analysis, what we found was essentially, yes, the patency was better with surgery, but the survival and limb salvage rates were not different. Stents, actually, stents have done pretty well with regards to patency as well as limb salvage. Here is the different trials from the basal surgery and the basal PTCA. Actually, they used the bare metal stent, which actually didn't do that well. But when you look at the drug-eluting stents from Paradise and Fawn, they've done pretty good. So when you look at atherectomy, these are the four basic kinds of atherectomy. Again, the data on this has not been very convincing, so the verdict is still out. The idea is to debulk the plaque, and therefore you achieve better luminal gain. And also when you use a DCB in addition to atherectomy, it helps with better drug penetration. With directional atherectomy, you have the definitive LE study where they looked at 145 below the knee patients. The bailout stenting rate is low, and as we've seen with reality data, which was recently published, they had good limb salvage rates. Sorry, this is orbital atherectomy. Once again, reduces the need for repeat revascularization. Laser ablation, as you can see with the LACI trial, with excellent limb salvage rates, achieving good luminal gain and patency rates. And then in rotational atherectomy, you have at least three kinds. And with the rotablator, not a lot of data, but if you look at some single center studies in heavily calcified lesions, they do help achieve better patency rates, especially by modifying the vessel. Here's the Phoenix atherectomy, and they have a registry going on where 52% of the 500 patients are CLI. So we have to wait and see what the data pans out to be. So with regards to atherectomy, yeah, they've all proven that when used appropriately, they are safe. But so far, it's not been convincing that, yes, they do improve your amputation-free survival. And therefore, this is not uniformly accepted as the to-go strategy by the CLI community. So when you come to what atherectomy to use, I think this is a good table as to where you can use, and as well as with regards to long calcified lesions or instant restenosis. But I think the most debated issue is whether drug-coated balloons will be useful for patients in infrapopliteal lesions. We know it works pretty good for femoropopliteal, and unfortunately, after the IMPACT DEEP study, which really didn't show any benefit, and also, in fact, raised concern that there was a trend towards increased amputation. So the debate BTK showed that yes, your restenosis and your patency does improve, but your amputation-free survival did not really improve. And then the Illuminate BTK study is ongoing. And then when you look at the Lutonix BTK, they found similar freedom from primary safety events and freedom from TLR. So this is some of the newer techniques where they use deep venous arterialization, especially in patients with desert foot. So essentially you connect the artery to the vein, and this vein kind of drains the actual ulcer, and you can do it percutaneously. They have had very good results with the PROMISE 1. I think right now the PROMISE 2 study is ongoing. So I think everybody is definitely waiting to see what this shows. And then you have the TAC optimized balloon angioplasty. These are almost like very, very short stents you put in. And as you can see with the TOBA 2, they have above and below the knee, excellent patency rates. And again, it's not a head-to-head comparison, but the rates are as good as drug-coated balloons, reduced TLR. But the key thing is the bailout stent rate was very, very low. So in summary, when you have to cross the CTO, and because you're going to encounter a lot of CTOs in infrapopliteal disease and CLI, make sure you pick the right kind of equipment. Always remember a retrograde approach, because that increases your success tremendously. Never stall in one action. Keep moving, go to the next algorithm, kind of build one mentally within yourself. And then the next thing you go is, what is the treatment strategies? Personally, the way I see is there's a lot of options, but nothing is really panned out. I feel that there's a lot of promise for drug-coated balloon. So tailor the treatment based on how long is the lesion, is it a chronic total occlusion, how much of calcification is there. And if you do see this, I personally think a atherectomy, and hopefully when DCB is available, it'll be great. And also, I always also consider using drug-eluting stents to get the job done. Thank you.